All right, welcome everybody. We'll go ahead and get started. There'll be more people joining, but we've got some introductory stuff to do. I'm Vivek Kulkarni. I'm the education editor for JACC, and I'm happy to welcome you guys to today's edition of the JACC Journal Club, where we'll be talking about the Odyssey-HCM substudies. This material was put together with Natalie Stokes and Harris Jared, who you guys will hear from in a little bit. Before we get started with the actual cardiology of the talk, just a reminder, JACC Journal Club is something we've been doing for a little over a year, where we have online webinar discussions of interesting JACC articles featuring the authors of those JACC articles in order to really get to pick their brains about interesting things. It's very exciting thing that we're able to do, and I'm happy to share it with you all. This is a CME accredited activity. So for those of you who get continuing education credits, this does qualify. In order to meet the requirements of CME, I am required to show you these slides on the screen. I am not required to read them out loud, and you're not required to read them. I just have to show them. So this is our statement of need. This is our overall goal and target audience. These are our learning objectives for JACC Journal Club. Credit statements for various professional societies. Disclaimer statements. Disclosures and conflict of interest statement in general, disclosures of the planners, faculty disclosures for today's session, and final slide with CME mentioned. These slides are all available for review online after the fact. All right, so today I'm very happy to welcome our discussant, Dr. Milind Desai. He has many titles, as we were discussing earlier before we started, but he is the Vice Chair of Education for the Heart, Vascular, and Thoracic Institute at Cleveland Clinic. And perhaps more relevant to us here, he is the director of the hypertrophic cardiomyopathy program at Cleveland Clinic, and was the principal investigator, senior author on all of the trials we're going to talk about today. So Dr. Desai, thank you and welcome.
Thank you for having me here.
Just to give everybody an overview of what this session is going to look like, we are going to start off with a very brief overview of the main Odyssey-HCM trial, which was not published in JACC. That was published in the New England Journal of Medicine. So we'll talk about that a little bit in order to lay the groundwork for a deeper discussion into the two Odyssey-HCM sub-studies that were published in JACC. We'll go into those in some detail. Along the way, we'll be asking Dr. Desai questions that we have already prepared. If you have questions, please put them in the chat. What we're going to do is we're going to aggregate these questions, and toward the end, we'll have a Q&A session, depending on how much time we have left, where we will be able to ask Dr. Desai some of the questions that you guys submit. In this WebEx platform, in order to make sure the questions are seen, when you look in the chat, there's a little box that says "to." You just have to make sure you put "to everyone," and then that way everybody can see the questions that you submit. All right, so these are the articles we're going to talk about today. The QR codes link to the articles in JACC. So if you guys want to, you can scan the QR code and find the article. It's also pretty easy to Google it. The first one is about echocardiographic changes related to mavacamten and non-obstructive HCM. And this is the second one, the effect of mavacamten on cardiac biomarkers. So these are the two articles we're going to speak about today in detail. Before we do that, I just wanted to start with a very simple polling question for the audience. Have you ever prescribed mavacamten? Hopefully the choices are pretty straightforward here. Take about 10 more seconds to fill in your answer. The poll should have popped up for you on screen. It should be pretty easy. All right, I'm not sure that I can easily share the results with everybody. It looked like the majority of people said no, and only a handful said yes, actually. So I think relatively little comfort with this medication, which is a good thing we're talking about it. All right, I will turn it over to Natalie Stokes to start with some background.
Great, thanks so much. So we are going to give a very brief overview of the primary trial and background for the impetus to this trial to lend some background for our discussion. So non-obstructive hypertrophic cardiomyopathy is a form of hypertrophic cardiomyopathy without LV outflow tract obstruction. And it frequently is associated with symptoms from a complexity of physiologic mechanisms, but currently there are no approved therapies for patients with non-obstructive HCM. And so on the next slide, this figure is taken from the initial trial description, and it has a lot of the different physiologic mechanisms provoking dysfunction and symptoms in patients. And before we go forward, Dr. Desai, just wanted to pick your brain a little bit, and something we'll loop back to at the end. Going into this trial and in your experience, are there specific predominant underlying mechanisms that you thought might be driving symptomatology in your patients? And we'll talk a bit about whether or not the findings in these studies support or have changed your mind on that at all.
So, in overall context, thank you once again for having me here. So, overall, in hypertrophic cardiomyopathy, obviously a large proportion of symptoms come from dynamic outflow tract obstruction. So, once you take that group out, we know there are other etiology, other drivers of symptoms, including as it states here, small LV cavity, not enough stroke volume, diastolic dysfunction, compliance issues, etc. Arrhythmias are a big proportion of symptomatology. A lot of times it's the atrial tachyarrhythmia, fib flutter. And as it shows here, there is also subendocardial ischemia driven a lot by microvascular disease. These tend to be the most common in my mindset. And then there's obviously fibrosis that results in advanced dysfunction and then downstream ramifications like pulmonary hypertension. There is, of course, a unique subset of mid-cavitary or distal cavitary obstruction, which is not your characteristic LVOT obstruction. That also patients tend to have symptoms related to that. So this is a hodgepodge of various mechanisms that could result in a symptomatic patient.
Okay, great. And they were all included in
Yes.
the trial, which we'll get to. So a little background is mavacamten, as you are aware, is a cardiac myosin inhibitor. So it targets sarcomeric hypercontractility. And it's been approved with wonderful results for symptomatic obstructive hypertrophic cardiomyopathy and is now in use. So the impetus for this trial was to see if the results would be similar for non-obstructive hypertrophic cardiomyopathy. The Odyssey-HCM trial was designed as a phase 3 international double-blind placebo-controlled clinical trial to determine if mavacamten improved functional capacity and patient-reported health status among adults with symptomatic non-obstructive hypertrophic cardiomyopathy. 580 patients were randomized, about 289 in the treatment arm, 291 in the placebo arm, and measurements were taken and compared to baseline in 48 weeks, including an echo. Stress echo was done at baseline to exclude LV outflow tract obstruction. The KCCQ-CSS test, which was the measurement for quality of life, CPET, and lab work, including biomarkers, which we'll be talking more about tonight. And so to cut to the chase, the primary endpoints were not positive. So among patients with non-obstructive hypertrophic cardiomyopathy, mavacamten did not result in significantly greater improvement in peak oxygen uptake or a decrease in symptoms when compared with placebo. You can see here it's relatively small on the side, but p-value of about 0.07 for change in peak oxygen uptake, and borderline as well, 0.06, but overlap in the confidence intervals. So now
this
question
goes
for
to
the
the
audience
second.
here is, how do you interpret this overall negative trial with a p-value of 0.06?
Yeah, David, if you could bring up the poll, please. Question here is, with a p-value of 0.06, how do we interpret this?
One second, the polls are having a little bit of trouble.
While you're pulling that up, I'll go through the choices here in case it doesn't work. A, do you interpret this that the drug definitely does not work? B, that this trial didn't demonstrate any effect of the drug and no further trials are needed? Or C, this trial didn't demonstrate any effect of the drug, but further trials are needed? Maybe in the absence of having a working poll, maybe Dr. Desai, you could weigh in on this question here. You know,
I feel like it's
all
slightly leading.
So, all right. It's the conversation for the next hour will not happen if we think the drug definitely does not work with a p-value of 0.06. So at this point of time, how do you look at this? It is in the chat, it says near miss. So what it does is it did not demonstrate statistically significant effect in the chosen primary endpoint of exercise capacity and patient-reported health outcomes. However, as we will discuss, there were some fundamental effects at a pathobiological level, but at this point of time, they did not translate into a statistically significant clinical benefit in this population. We will discuss about some of the potential reasons why that is. As the day goes on, but I do think, should we stop at this point of time? Probably not. We definitely, at the very least, we need to understand, is there a subgroup that responds better than the other? Yes, the overall population, it did not work, or at least it did not demonstrate statistical significance, but clearly the p-value is not 0.98 here. The p-value is 0.06, 0.07. So which subgroup it benefited, which subgroup we need to stay away from, or some of the things as maybe will be discussed, is the disease in some patients too advanced to a point where the horse is way out of the barn and it's too late? Should we be starting things earlier? Should we be looking at a subgroup of population? One responds better. Maybe, the diastolic dysfunction may respond better. I'm just throwing things out compared to somebody with subendocardial ischemia as the primary driver of symptoms. These are some of the things we need to. Responder analysis is what we need, clearly. Because, look, yes, the peak VO2 and KCCQ did not significantly improve, but as you are going to show, and I'll steal a little bit of the thunder, there was a 58% reduction in the BNP in the mavacamten group compared to placebo. So perhaps maybe our bar was set too high. So these are some of the things. So if I have to choose one of the three answers, it would be C, more investigation is needed. But that's me.
Yeah, no, thank you for going through that. I think for those of us who are not trialists and don't design trials all the time, I think it's easy to get lost in the sanctity of P of 0.05. So I think it's helpful to remember that. Natalie, go ahead.
Yeah, so let's talk a little bit about the sub-studies that we want to dive into a bit more here. So the first is the echocardiographic changes. And this was a pre-planned exploratory post-hoc analysis of the echoes from the Odyssey-HCM trial with the specific aim of evaluating echocardiographic changes of mavacamten compared with baseline to 48 weeks between placebo and the therapy group. So the key inclusion criteria for the trial, we didn't get into above, but you can see here, notably NYHA functional class 2 or 3, they had to meet all criteria for non-obstructive hypertrophic cardiomyopathy. peak LV flow tract gradient of less than 30 millimeters of mercury at rest and less than 50 with provocation. That's why a stress echo was done at baseline. LVEF greater than 60% and NT-proBNP level greater than or equal to the upper limit of normal. And then any one of the following, which is troponin greater than 99 percentile, some markers of diastolic dysfunction, or and LAVI greater than 34 milliliters per meter squared. So the basic design with this is all participants underwent a comprehensive echo. They did this actually throughout the study, as this is the way of assessing response to the medication and helping for dose titration. But for the purposes of this sub-study, they were comparing baseline with 48 weeks. Echo data was used for dose titration and also to assess safety and efficacy, and we'll talk a little bit more about that in a bit. All images were done and reviewed at a core imaging lab and blinded. The measurements that were taken are primarily listed here. Max LV wall thickness was done both in a parasternal long and short. LVEF was by Simpson's biplane. Dimensions were all taken here. Both SAM and LV outflow tract obstruction were evaluated at rest and Valsalva with at least 3 separate beats, both in AFib and sinus rhythm. Diastolic parameters, including mitral inflow velocities and your E to E prime. And strain, both LV global longitudinal strain and LA strain was performed. Each participant was categorized as having concentric, basal, septal, and mid-cavitary or apical LV hypertrophy. The baseline characteristics for the trial are listed here. Mean age 56, about 46% female, primarily white with a distribution as noted here, BMI of 28. About 43% had a family history of hypertrophic cardiomyopathy, 6% with prior septal reduction therapy, and the majority, about 80%, were on beta blockers. 70% NYHA class 2 and about 30% class 3 the time of enrollment. And now for the results, I'll try to blow some of this up so that everybody can see it. As opposed to the primary trial, these were fairly resoundingly and positive, and in ways that were of significant magnitude. So difference in EF was about 5% difference, or 5 in real time, so a LVEF of 5% less on average. And we will get into the safety criteria, but the majority were still enrolled. In terms of the other impressive things here, maximal LV wall thickness, I just want to draw your attention to, because I think this is so tangible to see, is a difference of 2.1 millimeters of thickness between groups, and that's statistically significant. And then end diastolic and systolic volumes similarly were impressively different. With regards to the diastolic function parameters, you can see most predominantly the average E to E prime was reduced between groups 1.3, which is, again, magnitude of significance that's fairly impressive. And then if you go on to the RV parameters, were relatively stable between groups, with an improvement in the RV S prime velocity between groups of 1.1. And then finally, we have our left atrial parameters, where you can see significant difference in the left atrial strain, most significantly both conduit strain and contractile strain. And so before we move on to summarize this, Dr. Desai, is there anything that you want to draw people's attention to from these results at base level that you think is important?
Yeah, so I think that thank you again for going through this. Important thing, if you go to the baseline characteristics, this population, some of the things you have, some of the things you don't. average duration of disease from diagnosis to enrollment was 10 years. So this was a long time diagnosis. About 30% patients had history of atrial fibrillation, their diastolic dysfunction. So there were multiple factors here that suggested that this population had advanced disease. So their baseline KCCQ score was also in the high 50s, which is significantly low. Their peak VO2 was also low. So long story short, this was a much more advanced disease population. Having said that, you can go to the next slide. Like you said, at the level of echocardiography, we were able to see significant directional improvement. That's the word I've learned in the last few weeks. And I have to thank Harlan for that. There was directional improvement in some of these key variables to almost, I would say, a similar extent as we have seen in the obstructive population, number one. So that's an important observation to make here. So things that, that's where the pathobiology is connecting with the drug. But again, I go back to the thought process. It is not reaching a level of clinical significance in this population. You can see some of the things, go to the next slide for a second. So if you look at the strain, for example, if you look at all comers, yes, the values are not significant, but then, you remove the bad apples. Of course, in a randomized controlled trial, you don't remove bad apples, but if you look at the right population, there is significant directional improvement. And the same thing we were seeing in the left atrial function. So the other important thing here, look, this was done blinded. Absolutely blinded. So there is in a obstructive HCM population, you see lack of obstruction, and then blindedness sort of becomes questionable. But here, there is absolutely no doubt the people had no idea who was on what therapy. So I think this is robust evidence of echocardiographic changes, many of which have been shown in other trials to be of significance, so including improvement in diastolic function, etc. But having said that, there is a fundamental disconnect in this population, at least in this trial, the way the patients were selected between what we are seeing on imaging and biomarker versus what's happening in terms of clinical improvement. Maybe the lesson is outflow tract obstruction causes much of the symptoms, a lot more than diastolic dysfunction. So, but that. These are my overall thoughts.
Great, thank you. And so just to summarize key results, there was a demonstrated directional improvement in LV wall thickness, diastolic function, and left atrial parameters, and I think a significant and meaningful way. The adverse events, this was in the primary trial. The mavacamten group had more study drug interruption, primarily due to reduction in LVEF, which was shown to be recoverable with discontinuation or dose adjustment of the drug in predominantly most everyone, except for a couple. And then otherwise, there was about an equal amount of atrial tachyarrhythmias.
So I may like to chime in on that for a second, if you don't mind. So this is important. Look, these are cardiac myosin inhibitors. So they are going to inhibit the cardiac myosin, right? So unlike in the left ventricular outflow tract driven patients, so obstructive HCM patients where you are shooting to improve the LVOT obstruction, here we don't have that. So our dose titration scheme here was predominantly driven by LV ejection fraction, right? So at the outset, we were expecting about 17% people with LVEF less than 50%. And in the mavacamten group, we saw about 20%, about 21%. So not too terribly far from what we were expecting. Now, again, it's a matter of the goalpost. If you set your goalpost that, we will only interrupt if your ejection fraction is less than 40%, then that number, but you count the cutoff at 50%, then that number would be different, would be much lower. But here, that's an important, important conversation to be had, that a lot of these ejection fractions dropped because we were titrating to that, number one. But most importantly, it was reversible reduction. So interruption of the dose or lowering of the dose and reinitiation, they reversed the ejection fraction. There were 3 patients. One of them withdrew consent at week 16, and the other 2 at the time of week 48 data cut did not return for their echo. So it is not to say that their EFs did not improve, but it is important to say that we just don't have follow-up data. Another important thing here that you don't mention, I think it is important in the context of this, is 19 patients, 19 in mavacamten group had congestive heart failure, but only 5 had that in the context of ejection fraction reduction. So that again goes to show that these patients have symptoms and congestive heart failure. They are sick patients. So they have various etiologies for developing congestive heart failure, and it's not all driven by ejection fraction.
And I think we'll be talking a bit more after the biomarkers about the correlation between some of these changes and patients as well.
Can I ask Dr. Desai, just from the perspective of someone who's designing a trial, how do you arrive at this 50% number? Because it could have been 45% or 40% or 55%, as you said, that might have changed things.
So that's a simple answer. We chose that cutoff from the guidelines. So HCM guidelines state that for HCM, which is a state of hypercontractility, the ejection fraction cutoff to be used is 50%. That's what my elders say. That's what I follow my elders, I guess. In ischemic cardiomyopathy and all other things, the cutoff is 35%. So here it is stated, if you have an HCM patient who develops what they call advanced HCM phenotype with reduction in LV function, the threshold below which you put a defibrillator is 50%. So that's why we chose 50% as being the threshold. And also, in the commercial utilization of mavacamten, the Camzyos drug, that is what the FDA has set as a threshold. So you could have an EF of 49%, and those of us who read echoes, it could be plus minus 5%. That if that number is written in stone, that's the number, and that's what we chose.
Makes sense. Thank you.
Great, thank you. So just here's a summative figure from this trial, which showed the randomization, the objective, and the main findings, which we just described. So the strengths of this study is it is the largest, most robust randomized trial in non-obstructive hypertrophic cardiomyopathy patients, and there was careful screening to ensure it was truly a non-obstructive population. The echocardiographic substudy was specifically rigorous, blinded, as Dr. Desai drew some attention to, truly blinded evaluation in a core lab with adjudication of all echoes. It is limited in the sense that it's a post hoc exploratory analysis, and the 48-week follow-up is a limitation, I guess, to be discussed. But
one comment I'm going to make, Dr. Stokes, is, to true nHCM population, I think we may have just glossed past it. Mm-hmm. Every patient at baseline not only had resting and Valsalva gradients, but also had stress echocardiography to rule out outflow tract obstruction. So in many databases, about 20% patients, up to 20% patients could have latent LVOT obstruction. So here we were very careful not to sneak in somebody with latent outflow tract obstruction who we know already benefit tremendously from commercial mavacamten. So something important to keep in mind.
Great, thank you. And so just a summary of this first sub-study is that the mavacamten was shown to promote directional improvement in markers of diastolic function, LV wall thickness, and LV mass index, but evoke no clinically significant improvement in exercise capacity or patient-reported health outcomes. And now we'll discuss a little bit more about the biomarker studies and then loop back to discuss as a whole.
Harish?
Hey guys, so this is the QR code for the biomarker trial for those of you who want to take a sneak peek at that, and we'll move forward this way. Okay, so Natalie went over a lot of the study objectives, and the biomarker association is much the same. We're trying to look at the association between baseline biomarkers. For the purpose of this was NT-proBNP and high sensitivity troponin, and the association of clinical and echocardiographic features. So we won't gloss over this too much, but we went over the patient population. Mavacamten was titrated between 5 and 1 to 15 milligrams per day versus placebo over the 48-week duration. And there were serial time points where echo was performed, at which point biomarkers were also obtained. And we'll go this way. Okay, so I think this speaks to the acuity of the patients in the biomarker sense. So the median NT-proBNP number was quite markedly elevated. We touched on echocardiographic features, but Dr. Desai, what percentage of patients had an MRI diagnosis at this point or at entry of the trial? And did you have any sense of what degree of fibrosis they had going into the study?
So unfortunately, we did not mandate that. And, there's an MRI sub-study, which will at some point of time look at this data. But MRI was not mandated as part of the entry criteria for the current trial. So we do not have the actual fibrosis LG percentage.
Okay, yeah, as is probably practice. And then pragmatically, BNP and troponin were picked. Did you guys ever explore non-clinically utilized biomarkers for fibrosis at all in the design phase of this?
No, I mean, this was designed as a practical real world application type trial. And, like you said, the heavy words you utilize, non-clinical, MRI
Right.
relevant. Yeah. So we did not do those. Now, not to pivot, but there's an ongoing HCMR registry, which has collected all kinds of biomarkers, including the fancy ones, and hopefully they will shed some light into the disease pathophysiology in the foreseeable future.
Great. Thank you for that. So the patients that were above the median values for the two biomarkers are slightly disparate. So female gender, atrial fibrillation, worsening symptoms, and lower peak VO2, as well as the echocardiographic parameters that Dr. Stokes mentioned, correlated with a high BNP, but your troponin value, you're likely to be younger, perhaps speaking to the population variety, and you're less likely to be white, and echo and peak VO2 as per usual. The VO2 marker was quite low in this population, again, speaking to the 10-year lead time before the diagnosis. I think that's relevant to reiterate here. We can go to the next slide. Dr. Desai alluded to the punchline here. The mavacamten group reduced NT-proBNP levels by 58% almost immediately, and the troponin biomarker reduction was over half. The placebo group, unsurprisingly, showed no change, and the reduction occurred early and is sustained over 48 weeks, and with some graphs to illustrate this nicely. This is a plot of essentially the change from baseline per patient. On the placebo mark, you see that 0 is a very highly represented, but over time, the bottom two graphs demonstrate NT-proBNP and troponin. There is a significant downward percent decrease of the biomarkers as depicted in graphical form. So we can go to the next slide.
One question I had about this before we move
Sure.
on. Waterfall plots are one of Harlan's new favorite things, or maybe old favorite things. So Dr. Desai, it's interesting to me, there's a lot of patients or some patients on the extreme end that had significant increases. Are these people you think that primarily experienced a significant reduction in their EF with the drug, or is there some other mechanism here?
Yeah, so I think, and there was, if you read the paper carefully, there is, between the two papers, I actually forget which paper had what, but the folks with the highest reduction in ejection fraction, okay, so the biggest delta from baseline for ejection fraction has had the lowest reduction in BNP and vice versa. So the highest reduction in BNP was seen in people whose ejection fraction did not significantly reduce. So yes, there is clearly some association between the two. And in other words, to sort of repeat what you, or to summarize what you said is patients who had significant amount of ejection fraction reduction, their response to biomarker was not that impressive. Yes, you caught that well.
Nice job, Vivek. We're gonna touch on that in a couple of slides, but it's a good point to make. A couple of journal club features. This is a nice use of a geometric mean ratio to baseline, comparing per patient changes. I'd encourage the audience to review this as I had to in the lead up to looking at this trial, and it showed a very nice sustained decrease in NT-proBNP and troponin. This is the slide for NT-proBNP, again, early and sustained, and the next slide shows troponin. This is very valuable for non-geometric parameters that are being assessed over the course of a trial, and you're looking at per patient assessments. So not surprising here, we can go to the next slide. The pro-BNP correlations and troponin correlations are pretty similar to the echocardiographic features described by Dr. Stokes, peak VO2, functional assessments with KCCQ, and several of the key ejection fraction, left atrial volume index, and diastolic parameters, in addition to wall thickness. So that's not surprising. And then we can go to the next slide. Safety endpoints, we talked about the two main points to hit on here. Again, I wanted to explore this, how sick was the patient population question. The patients with the highest change in biomarkers had the lowest change in ejection fraction, as Dr. Desai mentioned. This is in this study. And patients with the lowest change in biomarkers had the highest change in ejection fraction. Do you think that we can utilize this and run with this with regard to how sick the patient population was, and is it a kind of metric for us to be aspirational about catching patients earlier in the disease process when we're looking at these things clinically speaking?
That's the part. I think that's the key lesson here. Is we should be. It's kind of like riding the surf. You gotta get in on the surf a little early. I think that's the bottom line. Now, to be fair, I do think we have ongoing responder analysis that will shed further light, and I certainly am a glutton for punishment. So we are going to be presenting that data at AHA. So I have more work coming up to do the analysis. But yes, more data forthcoming. But you are along the right track in terms of your thought process. Yes.
Great. And then one thing that wasn't mentioned, I guess, in the two slide decks is that there is a small substudy of patients that did have a mid-cavitary gradient that was assessed and reported in the appendix. I'd encourage you to look at that for the audience. There is no meaningful change in the biomarkers there, nor the echocardiographic features, but it was an interesting kind of correlate to those a reasonable volume of patients. So I think about 44 patients in that little group. So as expected, the biomarker reductions were stark and from an echocardiographic standpoint associated with structural and functional improvements, with the caveat of the overall trial being quote unquote negative.
Thank you, Harris. So, just bringing it back to some of the discussion points we talked about, I guess we've been talking about this the whole time. How do we interpret this? The overall trial is negative with a p-value that's kind of borderline. There is definitely clear improvement in echo and biomarkers. Harlan and Michelle Kittleson wrote an associated, I don't know what you want to call it, editorial commentary in JACC accompanying these studies. The QR code is here, sort of bringing up how do we interpret secondary analyses, and what do we do with this? Do we try to design further trials? Do we say we need to select a different patient population next time? Do we need to get patients earlier? Do we need to get patients that have better functional capacity going in? Is there something different with the dosing? Do we need to try to exclude people whose EFs go down? There's all sorts of things that we can try to see if there is something meaningful. So Dr. Desai, I'm first of all curious, did you have a chance to read their editorial, and what do you think about what the sort of overall take home is?
I think you got some of the high points. One is, did we set the bar too high in terms of the primary endpoints? Do we need to be looking at different primary endpoints? Maybe these are not the appropriate endpoints. Look, this is what we have chosen, so you got to live with it. But in the future, should we be thinking about something else? Should we, like you alluded to, should we have an optimal dose, a slightly different dosing strategy where we are looking at EF? I mean, should we be looking at a different threshold of EF drug interruption? These are some of the things that we are looking at. The other important thing is, in the placebo arm for the primary analysis, there was a 10.4 point increase in KCCQ. That reflects that patients in clinical trial likely get better treatment than patients in real world. So that, we have to take that into account. And I think some of the responder analysis will help tell us if we need to refine the population. Clearly, as has been alluded to multiple times here, this is not a p-value of 0.98 where nothing changes. This is not where the placebo and the drug investigational product curves of biomarkers overlap. No, there's clearly something happening. It just did not reach the statistically significant threshold of clinical improvement.
Great. So I have a couple more questions to ask, but for those in the audience, now is the time to please enter your questions in the chat if you haven't already. We'll be looking through, and now's our chance to ask Dr. Desai some questions. One question I have is more of a practical one. One of the best parts of doing these sessions is we get to hear the inside scoop from people that actually design these trials and conduct them. So when you have a trial like this, that's maybe we can call it a near miss. How obviously this trial is conducted with industry support, and how does that play into designing future trials? Is that something that we have all these ideas of different trials we might want to do based on what we found in these sub-studies. Is that something where you go back to the drawing board and have full support to do whatever trial you want, or is that something that there are more limitations on how you can enroll patients just for practical reasons? How does this all play out in real life?
So, I mean, look, I'm going to quote my favorite Albert Einstein, and say the definition of insanity is trying to do the same thing and expecting a different result, right? So I think that's, so we have to adapt. We have to, the first question is this a hard stop? The clear answer is no. So then do we need to completely pivot? Or do we need to slightly adapt? I think those are the three fundamental questions we need to understand and design next steps from. Clearly, this is not a hard stop, at least not in my mindset. It is not a major pivot. We need to look. None of us are in the business of you and I don't walk into a patient's room and say, you may feel like terrible, but your BNP is so much better. So just take a hike. Nobody wants to do that. We want something where there's meaningful improvement. And so we just have to be, thoughtful about who we need to study, where the biggest benefit of the biggest bang for the buck is going to be. And that thought process is ongoing. Now, nobody in this planet, there's only a few people. Today we found, there's only few people with unlimited amount of money, right? And, we have to be held accountable for how we utilize resources, even if you have infinite amounts. So I think, that piece, the accountability piece, is important. We have to design, if we are going to take the next steps, then we have to do it in a very thoughtful manner, where we don't want to look, at the end of the day, if a therapy is not going to work, the last thing you want to do is put patients in a placebo-controlled trial, right? So, but I don't believe there's anybody in this audience who thinks this is a complete no-go. All of us have seen something is happening. So I think we will come up with a thoughtfully crafted next step. I'm pretty confident of that.
Yeah, that's reassuring. We as clinicians, we often see these patients and have unfortunately nothing to offer them really right now. And many of them have heard of mavacamten and ask about mavacamten, saying, "Can I take this drug? Can you prescribe it to me?" I also feel like we would not be doing the topic justice if we didn't talk about getting access to the medication. That it's not always the easiest thing to get, even for people who have a clear indication with obstructive HCM. Are you aware of any sort of off-label uses for this medication in this population of non-obstructive HCM, that people are using it kind of, let's say, experimentally?
I doubt it. Look, in the United States, again, never say never. Humans are a creative species, right? They can figure things out creatively. But technically, every prescription that is done for mavacamten in the United States has to be done through the REMS program, the Risk Evaluation Mitigation Strategy program. So that is the what you call the law of unexpected benefits. Is thanks to the REMS program, now we have the largest database of HCM patients with echoes, serial echoes on a drug therapy that is that not publicly available, but that's available. I published off of the REMS data. We have for as best as I can tell, this is very well scrutinized by the government and by the company, such that there's no creative uses of this drug in an off-label format. But humans tend to be very, very creative. So I don't know the answer to that, but as best as I can tell, the answer is no.
Great. And one other question that I had reading this that hasn't really come up yet in our discussion is, to what extent is there an effort to coordinate treatments for non-obstructive HCM with, let's call them more classic textbook treatments for heart failure with preserved DF? We know that certain treatments in that group definitely make people better, make people feel better, improve biomarkers. Some of them are new and exciting. Is there any role to including in the trial design for non-obstructive HCM trials some sort of stratification or randomization based on certain types of heart failure therapy?
Yeah, so there's obviously, the SGLT2 class of drugs. There is clearly some overlap between HFpEF and non-obstructive HCM. So it's natural to think, and I know there's plenty of practices that have incorporated SGLT2 into their treatment algorithm for non-obstructive HCM patients. There is an ongoing trial, Sonata-HCM, which is testing a novel SGLT2, not SGLT2, but a broader effective type drug compared to placebo. If that works, maybe that will add another weapon against the treatment of this disease. So look, there's plenty of stuff ongoing. The key is, I strongly believe we are just getting started. 5-7 years ago, there were 0 randomized controlled trials in this space. And pretty much if you open the guideline document, the ACC/AHA guideline document from like the last iteration, like in the 90s or the 2000s, I would say there was not a single indication based on level of evidence A. It was all consensus opinion of people sitting in a dark hotel room coming up with things based on no prospective data. Now we cannot spend a year without having a new prospective trial coming out in this space. So innovation is an important thing, and today we are here talking about a p-value of 0.06, but this p-value of 0.06 will trigger a lot of new things happening in this space. So 5 years from now, it'll be a whole different conversation. I have no doubt about it.
One question that came up in the chat was about population heterogeneity. I'm assuming that refers to sort of differences by race or differences by gender. Was there anything that was noted about that in the studies we discussed?
Subgroup analysis did not demonstrate at least race and sex related or regional differences. Now, there may be a heterogeneity. The Dr. Alfiris may be referring to is, different spectrum of diastolic dysfunction or the symptom. You are a short of breath non-obstructive HCM patient, but symptoms could be due to diastolic dysfunction, and somebody could be due to subendocardial ischemia, somebody could be arrhythmia. And the responses to these 3 patients may be different. So that's something we need to sort out in the responder analysis. But the race, gender, regional differences, not really. Not that we could see.
Okay, great. And then another question that came in the chat was sort of about when you feel comfortable using mavacamten in someone with a baseline borderline LVEF, which I think I can expand a little bit into a broader question, which is that many of us are not don't have a world-class HCM center just down the hall. And when we start people on mavacamten, a lot of these patients need very frequent monitoring, frequent echoes, very careful attention. Are there certain patients where either based on their EF or based on their symptomatology up front that you feel like, they really should be referred to a comprehensive HCM center in order to even start the therapy?
So look, I don't want to sound paternalistic when I say that, but I'm going to play on the Cleveland Clinic logo. Every world-class HCM heart deserves a center of excellence care, I guess. So yes, that is the guideline. In the guideline, it says you should, at least be tied to a center of excellence so that you have access to all the options, shared decision making. In 2025, if you're an HCM patient, it's not just about access to a high-class myectomy program or an ablation program, or a REMS certified cardiologist. It's also access to clinical trials, gene therapy, new trials, this, that. So I do think it is important for patients to be aware of that. Having said that, educational efforts will help level the playing field to a certain extent, where, it could be shared management, where you and I can share patients, where they avail of you being their local cardiologist and me, where they make an annual trip. I mean, that model works and works well for a lot of patients. Now, the specific question, would you feel comfortable giving mavacamten in borderline EF? No. Well, mercifully, we don't have to make that decision. The REMS program makes that for us. No, you cannot get the prescription of mavacamten unless your ejection fraction is normal. And now what this has also done, if you think about it, is law of unintended positive consequences. Is it has elevated the echo game a lot, to a point where people have gotten much better at getting echocardiogram, better quality echocardiogram, better Valsalva maneuvers, better everything. So I think, this is a team sport, and you don't win no Super Bowl with just one quarterback. You need the whole team.
Great. Well, we only have about a minute left, so I just want to say thank you, Dr. Desai, for doing this. Thank you, Harish and Natalie, for putting together all the slides. For those who are watching, this session is recorded. Will be available on the JACC website, usually within about a week. And again, this session does qualify for CME credit. So if you are planning to claim CME credit, please fill out the evaluation that you will get. Thank you again, Dr. Desai. I really appreciate you doing this, and we'll be looking forward to the next iteration of trials to see what's coming.
Thank you so much. Best of luck, and thank you for having me.
Take care, everybody. Have a good night.
Thank you, Dr. Desai. See you.
Thank you. Bye. Take care.
Thanks, Dr. Desai.